My name is Dana Goldman. I'm the director of the Schaeffer Center for Health Policy and Economics, and I want to welcome you to the Richard N. Merkin Distinguished Speaker Series hosted by the Schaeffer Center. And today we're really pleased to have two distinguished guests speaking about adult life expectancy disparities and the role that both education and race play in explaining them. Before we begin, though, I want to thank Dr. Merkin, whose philanthropic leadership and commitment to improving healthcare helps the Schaeffer Center bring prominent policymakers, experts, and industry leaders to discuss some of the most pressing problems in healthcare facing the United States. Today's program will include a brief presentation from our speakers, followed by some Q&A, so feel free to submit your questions in the box. And let's get started. I first want to introduce Professor Ann Case. She's the Alexander Stewart 1886 Professor of Economics and Public Affairs Emeritus at Princeton University. Professor Case is a research associate of the National Bureau of Economic Research, a fellow of the Econometric Society, a member of the National Academy of Sciences, the National Academy of Medicine, the American Academy of Arts and Sciences, and the American Philosophical Society. We're also joined by Sir Angus Deaton. He's the Presidential Professor of Economics at USC and a Distinguished Fellow at the USC Schaeffer Center. He's also a Senior Scholar and Professor Emeritus at Princeton University. He was the recipient of the 2015 Nobel Prize in Economic Sciences. And they both are the authors of Deaths of Despair and the Future of Capitalism, which was a New York Times and Wall Street Journal bestseller and was shortlisted for the Financial Times and McKinsey Business Book of the Year. And recently, they've been working at least 2 decades on trying to understand socioeconomic disparities in the United States. And we want to welcome them to present their most recent findings from the proceedings of the National Academy of Sciences and from wherever else it may arise. So thank you both, and I'll turn it over to you.
Thanks very much, Dana.
Thank you, Dana. Such a pleasure to be with you again. And we're so much looking forward to the day when we can be back being with you in person. Today, we're going to talk about a paper that was just released about a week ago in the Proceedings of the National Academy of Sciences. The research grew out of work we had already been doing, where we really found that a 4-year college degree was increasingly important for jobs and for a good life. The political philosopher Michael Sandel has recently written that the college degree is a condition of dignified work and of social esteem. And we argue in the book that changes in the labor market for less skilled workers have put them at risk. And what we find is that the third of American adults who have a BA are living longer lives and more prosperous lives, but the people without a BA are facing risks of higher mortality and declining prospects. That's certainly something that we've seen during COVID, but the work that we've done suggests that that was happening even prior to that epidemic. I'm going to turn it over to Angus, who was the data man on this particular project.
I'm very proud of that since it's rare that I'm the data guy. I don't usually trust myself this far, so let's hope this is right. So let me start by explaining something you're looking at here. This is not life expectancy, which is what people are sort of used to. It's related to life expectancy. It's not even life expectancy at 25, which would be the expected number of years you have to live at 25. And I have those slides, and we'll show you those later if anyone wants to see them. What this is something that's called temporary life expectancy, though it's a very strange use of words, which is how many years would a 25-year-old expect to live before their 75th birthday, okay? So pretend everybody dies at age 75, or we just don't bother with it anymore. And so we look at life expectancy for 25, given that everyone's going to die on their 75th birthday. Okay. Now, of course, like life expectancy, these are what are known as period measures. So what you're looking at is not really how long a 25-year-old expects to live, but how old a 25-year-old would expect to live if the mortality rates today stayed the same from 25 through his 75th birthday. And so it's really just a summary of each year's mortality rates, but it's one that has a sort of nice interpretation in terms of the number of years you would live if the mortality rate were constant, which of course it's not going to be. Now notice also, if between 25 and 75, the maximum amount of time you can live is 50 years. Because if you're still alive at 75, which is my age, you're gone, okay? So the maximum you can get is 50 years. So here's these pictures now. So expected years of life from 25 to 75, and this is each year from 1990 through to 2018, okay? And this is people with a BA or more on top here, they live longer. The whole population, the dotted lines, the line in the middle, and people without a BA. This is irrespective of race. This is everyone in the US population. What are the black dots? The black dots are to check that my calculations match up with what the CDC says they ought to be. So the CDC does not publish these numbers by education, but they publish them for the whole population. And the CDC has all sorts of tricks and data access that we don't really have and so on. And so it's nice to check that at least for the whole population, I get these things right. Okay, now let's get to the substance of this thing. The BAs, you see it going up after about 2005. That rate of increase slows a bit, but it goes on improving. That's the big deal. For the whole population, this life expectancy, this shortened life expectancy, after about 2010, it actually reaches its peak at 2012, and then it begins to fall. It picks up a little bit in the last year. There's no dot there because the NCHS have not published that data point when we made this paper. But if you look for the people at the BA, they reached their peak in 2010. And from 2010 all the way down, they've been decreasing. There was a slight welcome uptick in 2018 over 2017. And of course, I'll talk a little bit in question time about COVID, but for the, none of these things are going to get better because of COVID. So the big story here is this life expectancy for the whole population has stalled. It's been falling for a few years. For people without a VA, it's been falling since 2010. Things really got bad after 2010. All right, so now let's look at race, ethnicity, and sex. So the left-hand side is men, the right-hand side is women. They're on the same scale here. So women are closer, have a better chance of getting to this 50 years than men do. And you can see the differences by race. The Hispanics are always on top. They live longer than whites. Whites are in the middle, and blacks are at the bottom. Now, people are often puzzled by the Hispanic thing. It's called the Hispanic Paradox, just because people think that socioeconomic status is lower for Hispanics, and you would expect them to have lower life expectancy, but they actually don't. And who knows? There's a lot of immigrants in that population, a lot of other things going on. We won't have a lot more to say about Hispanics, except about COVID. Again, the circles are to do with what the CDC says. For whites, you've seen this already. What you can see here is that women are doing much worse than men, and that's something we'll see over and over again. Some of that is because, at least up until the turn of the century, a lot of the gains for men came from reductions in cardiovascular disease and reductions in heart disease. Women don't die from heart disease as much as men do. So that reduction, even if it was proportionally as high among women, doesn't give them the extra years that it gives to men. So you find this flattening for women throughout this whole period. For blacks, it's sort of more interesting, which is you've got this enormous gap here of more than 4 years at the beginning. which by about 2010 had shrunk to less than 2 years. A major change in the black-white gap. And then what happens is the bad things begin to happen after about 2010. And some of this is due to the opioids hitting the Black community, which it hadn't hit before then. A bit less for women, but Blacks not doing as well. This gap has not gotten any narrower after about 2010. The black-white gap is the same. So we're 2/3 done now. Here's my last slide, which is now we drop Hispanics for the moment. I have the slide with Hispanics on it if anyone wants to see it. But we're now looking at whites and Blacks, men and women, BA, no BA, okay? So the dotted lines are for people with a BA, men and women. The solid lines are for people without a BA. And what you can see here is that the educational gaps, which were pretty small back in 1990, here's Blacks with and without a BA, whites with and without a BA, have now gotten huge in 2018. So that as the white-black gap has shrunk, and this is happening for women too, the educational gap has really widened. And one way of seeing it, which is, we think, pretty remarkable, is that Blacks without a BA and Blacks with a BA were much more like one another than they were like whites with the same educational qualification. Now, when you go up here, whites and Blacks with a BA are much more like one another than whites with a BA are like whites without a BA. So this gap is very large compared to this gap. So this is the sense in which education is becoming more important than race as a stratifier for these life expectancy measures. The way some people would put it is that class is beginning to predominate over race. Now, in case we're misunderstood, and we get misunderstood all the time, it's very important to say that even within education groups, that these measures for Blacks are worse outcomes for Blacks than whites. That has stayed. It's just the gap has shrunk. The other thing that's worth keeping in mind is about 1/3 of the white population has a BA, and only 1/4 of the Black population has a BA. So the gaps are wider, unconditional on education, than they are in education. So I have supplementary slides, which I'd be happy to show you. I can tell you a little bit about what's happening with COVID. The supplementary slides basically say, if we look at adult life expectancy, which is life expectancy at 25, or we look at age-adjusted mortality, you get the same patterns. And so it doesn't really depend on what we admit is a somewhat unfamiliar measure of mortality rates, which is this 25 to 75 life expectancy rate. One advantage of using this 25 to 74, 75 measure is simply that it doesn't depend on the mortality rates of elderly people. And those are much harder to measure. And even the CDC uses all sorts of supplementary data sources to get at those. So these measures are clean from that point of view. Okay, I'm going to stop now. Anne may want to add a word.
Just a couple of things. One is that something that's happened for both Blacks and whites is that the progress we used to make against cardiovascular disease stalled. And it stalled for men, for women, for Blacks, for whites at about the same time, which is 2010. And there's something of a mystery there, which is if it were all due to just obesity, or if it were all due to just changes in smoking patterns, we wouldn't necessarily think that they would be synchronized in that way. So there's more work to be done, given how important cardiovascular disease is as a driver of life expectancy. So I think we can probably stop sharing.
Yep. Here we go. Back to you,
Dan.
Right.
Well, thank you. And actually, I want to jump off from that last comment about cardiovascular disease. But first, on the issue of where in the life cycle you're looking at mortality, I just want to point out that, Anne, you have done a lot of early work on socioeconomic gradients among children and how household wealth affects that. And we know that infant mortality drives some of these figures. And some of the racial differences in particular, but also I think the educational differences. And one advantage of looking at this age is that after people have become educated, it talks about the contributors to mortality that are different in midlife than they are early in life, where a lot of it is infant mortality. And then in the right tail, as you get to age 75, I think most people would understand that these gradients tend to compress at this point, and it's really luck and genetics that are taking over at that point. So, and so in focusing on that midpoint, cardiovascular disease is obviously an important area, but what are the other major causes that might be driving some of these differences?
A lot of it is opioids, of course. So, and I think when I was presenting it, I talked about how when the opioid epidemic got into the African American community, you begin to see bad things happening to blacks there too. So obviously deaths of despair, which is, our shtick, is an important part of this story. And in fact, if you were to look at the graphs I didn't show, the ones for life expectancy, adult life expectancy at 25, you would see they're somewhat more favorable, especially for Hispanics. And that's because life expectancy at 75 has been doing pretty well. And it's these midlife and younger people. The life expectancy measures tend to be biased towards things that are happening in the youngest people within your group. Because the derivative with respect to mortality at a specific age depends on how many years are after that. And that's much bigger for younger folks. So there are bad things happening increasingly among younger people.
Yeah, it's suicide, which we probably mentioned last time we spoke with you. Suicide, which Durkheim would have thought was something that hit people with a college degree harder than it hit people without a college degree. If that was ever true in the US, it certainly isn't true now. So it's people who have not been to college or people without a four-year college degree who are a lot more likely now to commit suicide and to die from alcoholic liver disease. So, and as you say, but this doesn't mean that early life doesn't matter for any of these things, because it puts people on different trajectories, and whether or not you end up with a college degree depends a lot on what happened between ages T-9 months and 18. Yeah.
And actually the causality can go the other way. We know that, for example, kids with asthma that's uncontrolled are less likely to finish high school than those with, part of that's your work, and not to say that you're the inspiration here. I think Angus does some good work with numbers, but, your work has shown that kids if you control a child's asthma, they're more likely to complete high school. And then I think we can infer that makes them more likely to complete college as well. So.
Yeah, this paper is basically a numbers paper, and we spin these stories around it. But we certainly don't want to rule out, and we think that's an extremely important line of causation, which goes from health to education, health in childhood, to health in childhood conditions, health in adulthood, and health in childhood also conditions the amount of education you get.
But also something you just said, which is when we started this work, African Americans had 20 years of real progress. Death from drugs and alcohol were falling nicely. Death from cardiovascular disease was really falling quickly. And so when we first started our work, we looked at whites because they were the odd man out. But now the work is really incorporating what's happening in the Black community too, because a lot of the gains that they made during that period are beginning to be lost to cardiovascular disease and from drugs.
I do think also, I don't know how much it contributes, but death from trauma and, homicide is an obvious example, but there are others, has actually declined more, I think, among Blacks than whites. So I don't know how it varies by age. But that also gets to, and I know this is a numbers story, but I want to talk to you about broadly about the evisceration of the safety net in the United States, or the degree to which this has happened. And maybe we could bring it back to, your book, and you've talked a lot about healthcare. And in cardiovascular disease, it's kind of surprising because we have so many treatments now that are available that can deal with the consequences of that disease. And Jim Smith has written on this and others. And so I wonder if you could talk a little bit about, what elements of the safety net, and you mentioned opioids as well, but healthcare and others that might help do something about this.
Yeah, it's a really good question. What we see in the NHANES, where we have blood tests, where we can actually look at a doctor's script on what happened with readings of blood pressure, is that uncontrolled hypertension is beginning to rise, and it has been rising now since about the 2014 NHANES, among people without a college degree. So whether that means they're not going and having their blood pressure taken, or whether that means they're not adherent, something here has got to change.
You've seen the adherence. I think you find that the adherence was going down a bit too on that group.
Especially we just know that the uncontrolled hypertension is up.
Going up.
Yeah.
Right.
Yeah.
Well, you can infer that's either you're not getting the drugs or you're not adhering to them.
Yeah.
But some of this is happening in other countries too.
Yeah.
Maybe not quite to the same extent. And in most other countries, we can't split this up by education. But it may be that we've sort of come to the limits of all these other drugs you were talking about. Mm-hmm. Either they're not working as well, or people are not going to the doctor to get prescriptions, or they're not taking them when they have prescriptions. But this was the big driver of decreasing mortality, especially among men. It was the same rate among women, but not in terms of life expectancy because they don't have so much of it. All right. So.
Yeah, we also, though, think we need to do more work on the relationship between the drug crisis and cardiovascular disease. Right. We know cocaine is like the perfect heart attack drug. Right. We know that alcohol, for example, will weaken the heart muscle. And given that the synchronicity of when we stop making progress and this skyrocketing of death from drugs, we think there's more work to be done to see whether or not that's a part of the story as well.
And I want to ask you, one of the interesting medical innovations in that regard. So if you look at HIV prevention, HIV was actually a big contributor to health disparities or life expectancy differences back in the late 80s when we didn't have treatment. The introduction of treatment changed it from a death sentence to a chronic disease. But now we even have prevention regimens, and some of them now you can take a shot once every 90 days, for example, rather than taking a daily pill. Not unlike birth control, I guess, and some others.
Birth control instead of birth control.
Right, exactly. And so
I presumably contributed to the black-white narrowing too, because there was the big epidemic of HIV among blacks.
Right, exactly.
And so that would really help.
But I think, this innovation that maybe it's not that the drugs are different, but how we deliver them and to improve adherence might actually favor some of the less educated.
Yeah, no, that's right.
Yeah. And so that's our next paper. So I'm going to recommend you as a reviewer. So that's just a sidebar of this.
Okay.
You mentioned COVID, obviously, and we can't do a webinar without discussing that. And how, obviously this has contributed to declines in life expectancy generally. but it's been at the right tail of the distribution. So does this matter for the 20 to this age range, or maybe 60? A lot of this difference you argued was earlier in the 25 to 75, but COVID. Anyway, if you could talk about COVID and what it means for this, and we'll have it.
Yeah, well, we did. There's a paper by Angus and Goldman, one USC, one Princeton, which is good, in the PNAS not very long ago. And what you see there is a big drop in life expectancy for Hispanics. So it's about 1 year overall from 2020. But much bigger for Hispanics. And the actual number of deaths among Hispanics is not that much out of proportion to the numbers in the population, but they're much, much younger. And so they take a big whack on life expectancy. And the same is true of African Americans. So any closing, it's reversed the Hispanic Paradox gap for 2020. Now, hopefully it'll go back again in 21, and if not in 21 and 22, but yes. And so COVID's making a big difference. The other, we don't know about COVID and education because we won't get the death certificates until the end of this year. There's one group at UCSF that very presciently got a deal with the California authorities to send them the death certificates in real time. And it's pretty clear that the excess deaths from COVID are much higher among people without a BA than people with a BA. I don't think those results have been published yet, but that's sort of what we would expect.
Yeah.
Right? It's the frontline workers, the people who are, the majority of people working in hospitals and health clinics and so on, the people working in meatpacking plants, the people dying in jail. Predominantly
people taking mass transit to get to work, people living in very close quarters in multi-generational families, all of those things that put people at risk. Yeah.
And actually, LA, this raises the issue of population density. And it turns out people think of New York as the most dense place because they think of people per square foot. But a lot of those people in New York are separated by floors. Yeah. And so they don't exchange air. But it turns out in Los Angeles, if you look at measures of density, like number of people in one bedroom, Los Angeles in some areas is the most dense urban area in the country. And it explains if you map that on top of where COVID deaths are, it's not surprising. And there's not much you can do about that, except maybe have had more enlightened housing policy 10 years ago to avoid the fact.
Yeah, but it's hard, right? Because you don't build the houses expecting a pandemic like this.
Yeah.
There's some other questions about Hispanics, which might be worth dealing with.
Yeah, I wanted to get to those. But I wanted to start with one that just asks whether these education gradients and race gradients are unique to the US, do you think? Or do we see this in other countries?
It's really hard to answer that question because the US is one of the only countries that puts education on the death certificate. So the education gradients are hard to come by. We're working right now with people at the Institute for Fiscal Studies in London to try to get them to merge their census in with their death records so that we can be doing more of this work for the UK.
But we do know that the education gradient is everywhere anyone's looked. Yeah. It seems to be Johan Machenbach in Rotterdam has done that for a wide range of European countries. And many countries have 1% censuses that can be merged into death certificates. That works for all-cause mortality. You can't get at the individual causes without having the whole shooting match. But that gradient exists pretty much everywhere.
In the UK, though, until COVID, and COVID changed everything there as well, It was the case that a lot of minority populations did better than whites. Angus is shaking his head no. I thought we
No, we don't
knew
know
that
that.
to be true.
It's,
Apparently we don't.
we don't know that. What we do know is that because they don't record that on the death certificate either. What they do record is immigrant status, and immigrants do very well, and a lot of those immigrants are minorities.
That's what I was going to say.
So we don't, and of course now in Britain, I mean, a lot of these immigrant ethnic communities, like the Indian and Bangladeshi ethnic communities, are not immigrants.
Right.
And so they're going to have to do something about this. That may be also why the Hispanics do relatively well here, because of a lot of Hispanics.
Right. And
That's
so
what a lot
that
of
gets to our
immigrants-
first question. Thank you, which is, how have the, what is there a different story for college educated Hispanics?
There aren't many of them, especially among the elderly. So, I mean, we have a graph of that, and nothing really very much is happening there. But, the number of Hispanic 70-year-olds with a BA is really extremely small. And so basically the result for people with the BA it's just very shaky to separate out those groups. And that's really why we don't do it in the paper. I mean, we have a graph, but it just shows the lines more or less tracking along together. So there's not much there.
Well, I do want to say I'm serving as the interim dean in our policy school, and we gave a degree to a Hispanic mother and her daughter simultaneously. So that was actually quite an inspiring story, but I don't know if you can.
I hope you'll track them until they die.
I was going to say, this is going to be a great experiment for you.
I mean, I don't think the Hispanic paradox itself is fully resolved, but it's clear that a lot of it is to do with immigrants, and immigrants are often not just healthier than the people they leave behind, but healthier than the places where they arrive. Some of it is attributed to tighter social bonds among immigrants. So all that living together was good for them perhaps until COVID came along, but it certainly has not been good for them during COVID.
Now, I know this is a numbers story, but a lot of the questions, and I think, we're a policy school, we'd really like to know, we spend quite a bit on healthcare, and we've spent quite a bit, for example, expanding access in the recent COVID bill to provide more subsidies to get people at about 400% of income to buy health insurance. Your work has suggested that a lot of this is driven by the socioeconomic determinants. And so if we wanted to move the needle, do you think at this point that you'd be willing to advocate that really this is about encouraging education, that there's a causal story here to reduce disparities?
I think there's a causal story, but not of the simple-minded thing that you might first think of, which
That's
is...
not the first time I've been accused of being simple-minded.
No, it's not you. It's a simple-minded idea that's out there. Where people would like to do a randomized controlled trial in which some people go to school and some people don't, and then you see whether they have a longer life. What we think is what we talk about in our books, that the way American society is organized has made it harder and harder and harder for people without a BA to get good jobs. So their employment to population ratio has been on a downward trend for more than half a century. Their wages have been, or men at least, their wages have been, median wages of people without a BA have fallen for more than 50 years. They don't have unions to support them anymore. They don't go to church anymore. So if you look at every aspect of their life, and yet people with the BA by and large have good jobs, they're benefiting from economic growth. And so there's this increasing divide between people left behind and people who have a BA. So it is a causal story, but it's not a causal story which if we give someone years more education, it will make them do longer. The other split.
That's not to say that there might not be something to it, right?
Yeah.
That when you go to college, it's really good for your executive function, that you might learn more patience, you learn how to stand back up after you've taken a fall. So we're not saying that there isn't something that you might learn in college that actually helps your health, but it's just not, we think the bigger part of it is that society is organized now around college, not college. Yeah.
Yeah.
I see. And
No,
so
that's right.
I think that was Mark Hayward calling you. He had a question. He's asking about the role that smoking plays here. So another lever for us is to, smoking has played an important role, and you've mentioned it several times, talking about cardiovascular disease and smoking rates. How much of this story is a public health story and one where we could make progress?
Well, I mean, where the smoking rates are highest, which would be like in the East South Central Division of the US. So that would be Mississippi and Alabama and I think it's Arkansas and Tennessee. I mean, so where tobacco was grown, tobacco is still, consumed. And their rates of lung cancer death are 2.5 times any other division, right? So, but that's a social, there's a social element to that as well, that there can be really good public health measures that you try to put in place, but I think you're going to have to hit it from some other angle if you want to see real progress against smoking. I mean, we have big progress. It's just, it seems to have again, leveled off.
It matters for the female-male thing, and has long mattered, because women were later to take up smoking and later to quit. But lung cancer mortality rates among women are now falling too. So that's not powering thing. I don't think, we fully disentangled why the women are doing so much worse than the men, especially white women who've had almost no progress. But, one of the things we're working on is, as Anne said, is a lot of these things are common across countries. And Britain is a particularly intriguing case because the perennial gain in overall life expectancy in Britain stopped in 2010, or at least it didn't stop, but it slowed to a crawl. So there's been very little increase in life expectancy up until 2018, and then in 2019 it jumped quite a bit. But a big debate in Britain is that the left is putting that down to austerity and the cuts in the safety net, which is sort of the argument there. But, it's the same disease, it's cardiovascular disease that's falling and so on. And unfortunately, we can't split them by education. But, our results, even for people with a BA, are not as good as English people overall, right? And Scotland, which is like the worst, where I come from, which is the worst performing for life expectancy in Britain. It used to be the Scots overall were about the same as Americans without a BA. But the Scots have now even left the Americans without a BA behind. So the Americans without a BA are sort of uniquely bad. But remember, just when you're asking, several questions are asking, what is it about education that does this? Well, almost all the opioid deaths, overall deaths, are among people without a BA.
Yeah.
So that's a huge factor in it. It's a huge, obviously, causal factor. So there's something about having a BA that keeps you away, and companies like Purdue targeted communities in the South, for instance, in Tennessee and in Alabama and West Virginia, where there were a lot of less educated people whose lives had come apart. And so it's not even a supply and demand story, it's sort of both going on together.
It's also the case, like alcohol and drugs and suicide, obesity rates are much higher among people without a college degree. And so, like, if you went up to like the 30,000 feet, I would say everyone needs something to soothe the beast, right? And people who are wealthier can go play a round of golf or go talk to their therapist or have a nice meal out with their very good friends in Los Angeles. But poor people, not as much. So they are looking for something to soothe themselves, and they're not finding it. So I think that, like, you might think of the obesity crisis as being part and parcel of this bigger picture of people's behaviors, which you wonder, well, why don't they take better care of themselves? Well, there's life is complicated and it's chaotic, and we're doing the best we can with what we've got, and that sometimes means drinking too much or smoking or taking drugs or too much ice cream.
Well, and that brings up the issue of the built environment. So we did a conference on obesity in Los Angeles, and some people from South Central said, look, I'd love to take my mother for a walk, but the sidewalks are uprooted and it's not safe at night and there's no lighting and we have to work. And you realize that, I live in Santa Monica, I can take a walk anytime, except during the looting. But so it brings up these neighborhood effects rather than these individual effects, and that these people are living in neighborhoods that may have communities that may have consequences for their health and mortality.
Right. We think these communities have deteriorated.
Yeah.
Because people without a BA, might have worked in a factory time where there was a strong union. They used to go to church. Their marriages have come apart. So there's just a whole tangle of misfortunes that have come to those communities. And, that's all part of it.
It was the case with the crack epidemic that the best readings of it that I've seen are that the communities themselves decided they would not tolerate this any longer, and that the communities were responsible for getting crack off the streets. But one wonders whether with the current epidemic of drugs, whether or not the communities are still strong enough to come together and to make that happen. I mean, the fentanyl crisis, which is like just out of control still, we say, well, it'll burn itself out. How do we know that? Because these things always do. But, with the crack epidemic, it was the communities that were really responsible. We don't see where this goes from here.
Well, the communities sort of got control of the prescription opioids by bringing all these lawsuits and things, which are still being funded. But, as the docs pulled back, it ignited this epidemic of illegal drugs, heroin and fentanyl in particular. And fentanyl is sweeping west across the United States. It's one of the reasons why drug deaths are rising very high and very fast in California during the pandemic, which of course the press likes to attribute to the pandemic, but which is, there was a pre-existing trend there. And a lot of it we think is fentanyl.
Okay, and we're running out of time, but I do want to ask one last question, because you mentioned some social supports like church and unions, and John Cacioppo has done some interesting work, on loneliness. And, I wonder about social alienation, and it's related to the work you've done, obviously, on opioid use and the lockdowns and such. And just where are you in thinking about that? Social alienation among the less educated as a driver here?
But the data show it.
Yeah, year on year in the National Health Interview Survey, people without a BA were more likely to say that they have difficulty socializing with friends, right? So we know that that's part of what's going on here. Marriage rates have fallen dramatically, right? So not a stable home life, not a stable work life, no longer going to church. And regardless of what you think of organized religion, it was an incredibly important institution in the US. And fewer than half of young adult working class whites affiliate now with any church. So we know that these people, it's kind of a Durkheimian recipe for suicide, is that they just don't have the supports. And we think that all of these things you can kind of pin back to a really lousy labor market that stops people from being able to get married. And
that labor market is lousy because healthcare costs so much.
Yeah.
Right?
We did that webinar, but we'll do that one again.
Okay. We need to do it every week, Dan. And we get all these doctors and hospital administrators to listen. Right?
When we get to the 20% of GDP, we'll have a celebration. But we're out of time. But I just wanted to say, you mentioned being with friends, and we miss both of you at the Schaeffer Center, and people enjoy interacting with you. And one of the themes that I hear all the time is your work is just so important, and you're asking such important questions that really affect the way our society is whether it's gonna progress or devolve. And so we're very appreciative that you take the time to work with us and to explain to our audience all these things. So thank you very much.